Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. The drug of the day today is going to be daptomycin. Before we get into that, make sure to go check out reallifepharmacology.com. We've got a free 31-page PDF for subscribers. Simply an email will get you access to that. So go take advantage of that for sure. There's tons of stuff in there that I've seen in clinical practice, as well as a lot of common things that show up on pharmacology exams and board exams throughout your career. So definitely go take advantage of that. 31-page PDF on the top 200 drugs. All right, the drug of the day today, as I alluded to, is daptomycin. Brand name of this medication is Cubicin. This is an antibiotic for infection. It's classified as a cyclic lipopeptide antibiotic. Mechanistically, this medication causes calcium-dependent depolarization of the bacterial cell membrane. And this is more specific to gram-positive bacteria. Okay, so that's primarily what daptomycin is going to focus on and obviously be helpful in treating. So by essentially inserting itself into that bacterial cell membrane, this generates an ion-conducting channel that interrupts or disrupts the integrity of that bacterial cell membrane. Okay, this causes intracellular components to be released, such as potassium, causes that depolarization, and ultimately can disrupt the bacteria. Okay, so as I alluded to, gram-positive organisms. In clinical practice, two of the most important organisms you're going to see with the use of daptomycin are Staph aureus, and more specifically methicillin-resistant Staph aureus, so that's MRSA. The other one is VRE for short, and that is vancomycin-resistant enterococcus. So as you can imagine, that overlapping coverage between vancomycin and daptomycin is pretty close. You know, we're really targeting those gram-positives and also targeting specific bacteria that tend to be more drug resistant, because if they weren't very drug resistant, we would simply use an ampicillin type antibiotic, which does a good job of covering most gram-positives. So again, that's really kind of the role of this medication. Can be used for a variety of different infections, skin and soft tissue infections, bacteremia, and so on and so forth. One really, really important distinction compared to vancomycin is this medication should not be used for pneumonia. Okay, so if there's one thing you take away from this, if you're preparing for a board exam, pharmacology exam, whatever, daptomycin should not be used for pneumonia. And the reason for that is the drug is actually inactivated by pulmonary surfactant. So definitely kind of a unique thing for this medication specifically. Don't use daptomycin to treat pneumonia. Okay, very, very important there. Dosage forms. This is IV injectable only, typically going to be once daily dosing. The exception to that is in poor renal function. Typically, this is going to be less than 30 mils per minute on that creatinine clearance. We may actually increase extend, I should say, the frequency. So instead of once daily dosing, we might go to every 48 hours. Okay, so that's something I'd encourage you to double check and look on if you've got a patient with poor renal function. What might be an appropriate dose given that situation. That usual dosing is based upon weight, so it's a weight-based dosing, anywhere ranging from 4, maybe even up to 12 milligrams per kilogram per day in some situations, in some very severe type infections. Obesity is a little bit of a different cat as far as dosing this medication. So it's a little controversial. I would say most of what I read is typically if patients are above a BMI of 30, we're probably going to use adjusted body weight to dose that medication. So if you're not sure what that is, I'm not going to explain it here. Kind of difficult to do the math without visually seeing it there. But that'd be a good thing to go look up if you're not sure what adjusted body weight is for dosing medication. So pay attention to that. If you know you got an obese patient, that is a situation where you'll want to ask, maybe double check, and you'll make sure we get the dose that we think is best in that patient. Again, it's a little controversial. There's not great evidence, but I think, overall, most experts' opinion are to use that adjusted body weight in patients who are above that BMI of 30. All right, let's get into adverse effect profile. As you could expect, the injection site, the infusion site, we could have some reactions there, some irritation, some itching, some redness, things of that nature. It is an antibiotic for infection that can often upset that gut flora, cause some diarrhea, cause some nausea potentially as well. Headache, maybe rash type reactions. Again, kind of all pretty standard with most antibiotics. The other thing, in addition, don't use this medication in pneumonia. The other thing I would strongly encourage you to remember is this medication is associated with myopathy and rhabdomyolysis. So elevations in CPK, that's a lab that we can check. Pay attention to that. Really, really important. It's definitely something that comes up in clinical practice as well as could show up on one of your board exams or pharmacology exams. So this medication can cause rhabdomyolysis and myopathy. And hopefully you remember from previous lectures, and I'll dig into it a little bit more, but statins can contribute to this as well. And I'll discuss in the drug interactions kind of how we might consider navigating that. Other things that are potentially associated, eosinophilic pneumonia. It's a very rare type situation, but it is associated with this medication. Typically, it's in longer usages of the medication. So if we give it for 3 days or 5 days or something like that to treat an infection, the likelihood of this is obviously much, much lower. It's more in longer term use. If we got to give it for a few weeks, for example, we're maybe more likely to run into this. Hypersensitivity reactions, rarely, maybe peripheral neuropathy. Again, very, very low incidence of those, but something to think about with this medication. All right, so monitoring parameters, that myopathy, rhabdomyolysis risk, we can check CPK to monitor for that. Also a good thing to maybe educate your patients on that. If you notice any notable new muscle pain or weakness, particularly all over, not in one location, that's not due to something that, they were doing or something like that physically. Definitely an important thing that we want to be alerting our caregivers and or patients about. Monitoring, so CPK, I mentioned that. Renal function as well. So remember, rhabdomyolysis can progress, can cause damage to the kidney, and that serum creatinine definitely can go up. So that's an important monitoring parameter there as well. Lastly, touching on pharmacokinetics before we get to drug interactions. It's IV only, so bioavailability is usually not going to be an issue there. It doesn't cross the blood-brain barrier that well, so that's potentially maybe a downside in central nervous system type infections. Half-life is in the neighborhood of 8 to 9 hours. Again, that's why we can typically get away with that once daily dosing. Elimination is primarily renal, in the neighborhood of 70 to 80%. So, as you could imagine, that's why we need to dose adjust maybe interval adjust and not give it quite so frequently in patients with poor renal function. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, BCM-TMS, or the NAPLEX exam, go check out meded101.com/store. We've got tons of resources there. We've helped thousands of pharmacists pass their board exams, and we can absolutely help you too. So go support the sponsor. It goes to directly help fund this podcast, keep it free and available for all to benefit from. So I greatly appreciate the financial support there. Also, if you're a nurse, pharmacy technician, dietitian, med student, anybody that needs pharmacology education, we've got other resources as well. We've got crossword puzzle books. We've got books on case studies and drug interactions and food medication interactions. So go check out all those links and absolutely support the sponsor, meded101.com/store. All right, wrapping up with drug interactions. One thing I was going to mention on the metabolic side is this medication is not significantly broken down by CYP enzymes. So that's a good thing when it comes to drug interactions. So the statin type interaction is simply due to additive adverse effects. Recall that statins or HMGA co-reductase inhibitors, these can increase the risk for myopathy and rhabdomyolysis. Well, when you start another drug that potentially can increase that risk as well, that can lead to ultimately a higher risk for myopathy and rhabdomyolysis. So what do we do about this? I would say historically, like several years ago, when I was closer to first being in practice, I would say statins were held. They were just held while daptomycin was given, and that was that. I would say we're maybe getting a little bit more evidence and a little less strict about that. You may have patients at severely high cardiovascular risk. Maybe they've had multiple heart attacks, multiple strokes, and then we get in that situation where that is a concern to us as well, in addition to the additive rhabdomyolysis risk. So it's really a risk versus benefit thing. I would say, lower dosages of daptomycin, shorter courses, we're probably less worried about giving them together versus, higher dosages, longer periods of time. We're probably more concerned about that additive risk for rhabdomyolysis. So, again, in practice, I've seen both ways. I've seen it, given sometimes with statins, and I've seen it held as well. So again, weigh that risk versus benefit. If we're going to give them together, we may want to monitor CPK and renal function a little bit more closely. So let's say you were going to do it weekly. Well, we may want to bump that to, every other day, for the first 3-5 days or whatever the case may be. So we can bump up that clinical monitoring and then obviously ask our patients as well if there's any type of increased feeling of, myalgia, muscle achiness, that type of thing. So a few different things we can do there. Obviously another option would be to try to find a different medication other than daptomycin to utilize that may treat their infection. Sometimes that can be hard to do, but that's another option there as well. So with that said, I think that's going to wrap up the podcast for today. Thank you so much for listening. If you enjoyed this episode, found it helpful, do me a huge favor, leave a rating review on iTunes or wherever you're listening. I greatly appreciate that. If you got any suggestions, comments, feel free to reach out to me at education101@gmail.com. Also, if you got any questions on board exams and study materials, if you're a pharmacist or pharmacy student, definitely don't hesitate to reach out as well. You can connect with me on LinkedIn too, Eric Christensen, PharmD, BCPS, BCGP. With that, I'm going to sign off for today. Thank you so much for listening. Take care, and I hope you have a great rest of your day.